Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers, to this One World, One Vision comprehensive course on strabismus. Today's lecture is on special strabismus syndrome. If you're new to this series, I'm glad you're here. If you're a repeat viewer, I hope that means the series has been valuable to you. I'm Bert Kushner, and I am the moderator of this series. And I'm delighted to introduce today's speaker, Dr. Linda Dagi. Dr. Dagi is an Associate Professor of Ophthalmology at the Harvard Medical School. She's the Director of the Adult Strabismus Service and a consultant to their Craniofacial Team. She holds the Children's Hospital Ophthalmology Foundation Chair, and she's particularly involved in researching innovative surgical techniques for the management of complex strabismus and has a particular interest and emphasis on craniosynostosis. She's trained 50 fellows and authored over 75 publications. She's also the past chair of the Adult Strabismus Task Force of APOS and was the first elected female member of the Association for Research in Strabismus, also known as the Squint Club. I can't think of anybody more qualified or knowledgeable to give this particular lecture, and it's my pleasure to turn this over to Dr. Dagi.
Okay, today you're here to speak about special strabismus syndromes, and thank you very much for the opportunity. The topics we're going to cover today are Duane syndrome, Brown syndrome, congenital fibrosis of the extraocular muscles, heavy eye syndrome, post-buccal strabismus, and strabismus related to craniosynostosis. Duane syndrome. What is Duane syndrome? It's a form of congenital disinnervation or miswiring of the sixth cranial nerve, and sometimes the third cranial nerve, primarily impacting the lateral rectus and medial rectus function. There are typically considered to be three types of Duane syndrome. There's esotropic Duane syndrome, or type 1 Duane syndrome, with notable limitation of abduction. There's exotropic Duane syndrome, or type 2 Duane syndrome, with notable limitation of adduction. And finally, there's type 3, which has significant limitation of AB as well as adduction. Esotropic Duane syndrome is the most common and typical form. There's underdevelopment of the sixth cranial nerve, sometimes appearing as absent on neuroimaging, with a miswiring of this aberrant sixth nerve to the medial rectus as well as to the lateral rectus. There's limited abduction resembling a sixth nerve palsy, but there's also co-contraction of the medial and lateral rectus muscle during adduction, causing a kind of a retropulsion or inpulling of the globe. So what does that look like? You can see in the upper slide that this gentleman has a Duane syndrome of the left eye. The left eye does not abduct. You can see in the outermost image. In the center, he's nearly orthophoric, but still a bit esotropic. And you can see that there's an inpulling or a retropulsion of the left eye as he looks to the right, making the eye appear smaller. It's sometimes easier to see this retropulsion if you tip the head down and you look at the two eyes from above. And here he has a head turn left, eyes gaze right to enable fusion, and you can appreciate his head turn in the picture on the bottom. You may also see an upshoot or downshoot as the eye attempts to go into adduction. And you can see in the leftmost slide on top, the left eye elevates or upshoots as she attempts to go into adduction. What's the treatment for Duane syndrome that's esotropic? For esotropias less than 25 prism diopters in primary, I usually perform an adjustable medial rectus recession with an augmented superior rectus transposition to the lateral rectus. If the esotropia is greater, between 25 and 50 prism diopters, I usually perform adjustable bilateral medial rectus recessions going over to the non-involved eye, plus an augmented superior rectus transposition. When you transpose the superior rectus to the lateral, you need to cut the frenulum, or the fiber connecting the superior rectus to the superior oblique below. If you don't, you'll pull over the superior oblique with the transposition, performing a kind of harada ito at the same time, which is not desirable. Note that augmentation can be graded. You can see in this image below that there are 3 extra sutures. I place them in this case at probably 6, 8, and 10 millimeters behind the superior rectus and lateral rectus border. When I tie down the one at 6 millimeters, the one most proximal and closest to the cornea, if you will, you'll get a moderate degree of augmentation. You'll get more augmentation if I tie down the one at 8 millimeters back, and even more if I tie down the one at 10 to 12 millimeters back. The further back you augment that transposition, the greater abduction you'll get, but you also risk possible impact on vertical alignment of the eye or torsional impact. I like to do this in an adjustable graded way because in the recovery room, if I have too much limitation of elevation or a torsional problem, I might slip Westcott in and clip the augmentation at 10 millimeters, leaving only that at 6 and 8. So there's a way to adjustably grade this augmentation. You'll get greater esotropia in some cases of Duane syndrome, and when it's more than 50 prism diopters and you have a very large head turn, you might want to consider an adjustable medial rectus recession plus a Nishida-like transposition of both the superior rectus and inferior rectus to the lateral. This way you can do a vessel-sparing transposition of both vertical rectus muscles, accomplishing your goal. The power of an SRT, superior rectus transposition, or Nishida-like transposition to the lateral is always greater if the lateral rectus is taut, because then it's a firm muscle and the transposition is really quite strong. If the lateral rectus is quite weak and there's really been full disinnervation, the power of the transposition is always a little less. Here's a Duane's ET on top with -5 abduction of the right eye. You can see on the top row of pictures, and retropulsion with adduction. Here's that same patient post bimedial recessions and an augmented superior rectus transposition of the right eye. You can see he has some capacity now for abduction of the right eye. You can see in the leftmost images, nice and straight in primary. Actually similar to a little less retropulsion, but a good range of binocular single vision. Here's how you can use these procedures to reduce the head turn or the ocular torticollis. Here are pre and post photos of an adult and a child, both treated with medial rectus recession and superior rectus transposition for Duane syndrome. In the left photo of the gentleman, you can see in the upper series of pictures. He cannot abduct that right eye at all. It's almost a -6 abduction. Here he is, post-immediate rectus recession and SRT on the bottom with loss of head turn. And on the bottom set of slides, you can see that the left eye of this child cannot abduct. The limitation is not as great as it was with the adult, but here he is with much improvement after medial rectus recession and superior rectus transposition augmented. For upshoots and downshoots, what can you do? There's a couple of possibilities. You can recess or Y-split the lateral rectus, and this may resolve the upshoot or the downshoot. Sometimes it occurs because of a kind of a tiddlywinking of the eye. If the lateral is very tight and the eye tries to go into adduction, it'll sort of flip up or down. So if you have a very tight lateral and you can almost feel that tiddlywinking of the eye under general anesthesia, that is a great procedure. If you don't have that, sometimes I find that inferior oblique weakening, though not typically done, may actually help. And here's a case where an inferior oblique myectomy plus bimedial recessions were done, and you can see there really is reduction in the rightmost set of pictures of that upshoot. What about Duane's XT? In this case, lateral rectus function remains quite good, but there's still co-innervation of the medial rectus, which reduces medial rectus function or the capacity to adduct. And here you can see that in this patient's left eye, he's got an exotropia, and in the leftmost picture, he cannot adduct. These are often treated with a lateral rectus recession. The case shown below illustrates a reduction in the adduction limitation and the loss of the upshoot with a large lateral rectus recession. The patient was intentionally left undercorrected, so he doesn't have very good adduction of this eye to avoid symptomatic diplopia in left gaze. I have found with these patients with Duane syndrome, if they are binocular, they become used to an area of double vision to one side or to the other in left or right gaze, and sometimes they don't appreciate full correction of the limitation in primary position if it gives them an area of diplopia in two different directions, both left and right gaze. And so that goes into my thought process when I'm planning surgery. Here's a type 3 Duane syndrome with poor abduction as well as adduction of the right eye. So if you look at these photos, you'll see the right eye doesn't look inward very much or outward, giving her an exotropia in left gaze and an esotropia in right gaze. You may consider surgery on the contralateral eye to reduce the duction asymmetry, but in many of these cases, no surgery is performed as the patients maintain minimal torticollis, rarely revealing their misalignment to others. They tend to turn their head more, and if they are binocular fusers, you can really count on that, and others do not often see this type of deformity. Let's move on to Brown syndrome. Brown syndrome is a mechanical restriction of elevation and adduction, often with secondary torticollis to fuse. And if you have a child with Brown syndrome with ocular torticollis, I really want the parents to watch that torticollis and make sure it stays. If the child stops exhibiting the torticollis, they've probably lost binocular fusion, and it's a bit late to intervene in terms of attempts to maintain binocular fusion. So I love that ocular torticollis. They are maintaining their area of fusion. In primary cases, it's considered a superior oblique tendon sheath syndrome. It's still somewhat poorly understood, but there's something that restricts movement of the superior oblique through the notch. In secondary cases, you can have a mechanical restriction of elevation and adduction due to an orbital cyst in that region, tumors in that region. It can be iatrogenic from ear, nose, and throat surgery through the sinus, creating some scar tissue in the supranasal fornix, or actually hitting the superior oblique muscle. Treatment. Congenital cases. First of all, many cases improve over time without treatment. I've almost never seen a case of a severe Brown's improve over time, but I've certainly seen cases of less significant Brown syndrome improve over time. It's also noteworthy to share with the parents the fact that when a child is very young, they're often looking into upgaze to see adults, but when they become older, into their teen years, they're rarely looking in upgaze. They tend to look straight ahead at other people, and others will not notice this deformity as much. As treatment includes some form of superior oblique weakening, I often like to delay treatment until later childhood to avoid diplopia and, more importantly, to avoid suppression in reading position or down gaze. You don't want to give the child a superior oblique palsy and a different form of ocular torticollis and a form of diplopia in an area where they more commonly reside, which is in reading position or down gaze, to run down a flight of stairs, bicycle, play with their Legos. So while waiting, you might wish to take them under anesthesia in the office and try an exaggerated traction test. This involves grabbing the eye with a forceps and pushing it into elevation and adduction. Sometimes if there's something minor that's blocking that ability, you can break some kind of a tractional limitation, maybe a piece of scar tissue or some atypical fiber, and actually cure them of the Brown syndrome. If you operate, I usually consider a recession of the superior oblique or superior oblique tenotomy with a suture spacer, or a partial posterior tenectomy of the superior oblique. In other words, I prefer to perform some form of graded weakening of the superior oblique muscle. In cases of severe Browns, you could consider a complete superior oblique tenotomy, but you might want to do an inferior oblique myectomy at the same time, or you'll quickly see the impact of a complete superior oblique palsy over the year to follow. So how does adjustable suture spacer technique work? Well, you isolate the superior oblique supranasally. You're going to place two 5-0 Merceline sutures secured several millimeters apart in that supranasal quadrant. You'll perform a complete tenotomy. You'll tie the ends together with an adjustable noose, and I use the sliding noose to optimize the spacer length. The spacer lengths are typically between 2 millimeters, which is very tiny. I've never really done them that small, and about 7 millimeters. I find about 4 millimeters is about right in many cases. And once I place it at that distance with some sort of adjustable noose, I'll then test the eye with ductions under anesthesia and make sure that I've resolved most of the Brown syndrome. If you find that you completely relieve the Brown syndrome and there's no superior oblique tension, that spacer is too long. You're going to soon see the impact of this as a non-graded procedure as a complete tenotomy. So you have to have some tension in that area. You'll probably notice undercorrection after surgery, but that will readily go away over the year to follow, because as you reduce superior oblique tone, inferior oblique overaction will begin to occur, and you'll get better elevation and adduction over time. Here's a case of a left Brown treated with a superior oblique tenotomy with a spacer. Pictured on the left-hand side, you can see that the left eye does not elevate well in adduction. And here she is many years later, a good number of years after the superior oblique tenotomy with a spacer, with really normalized superior oblique function and no ocular torticollis. Does it always work? Well, I did a study with our department looking at graded tenotomies. The thought with graded tenotomies compared to superior oblique complete tenotomies that you would avoid superior oblique palsy. And I found that that's actually an over-exaggerated claim, that it relieves the Brown in 90% of patients. However, if you look over about 10 years, about 30% of them will develop some evidence of superior oblique palsy and a different kind of ocular torticollis to fuse well in primary. And I found that to reduce the risk of the development of consecutive superior oblique palsy, it's best to operate if the hypotropia in the affected side gaze is greater than 16 prism diopters. In other words, if they have a minimal hypotropia in the affected side gaze, you're going to induce a superior oblique palsy. But if you have a fairly big hypotropia in the affected side gaze, you probably won't. And this is probably a reflection of the fact that in those cases with greater hypotropia in side gaze, you start out with overacting superior oblique, so you can afford to lose some of that tone. Acquired Browns. You may want to image. You may find a cyst or mass at the trochlea. You may consider a steroid injection if you think it could be an inflammatory cyst, and I find that that helps maybe in a third of cases. You may also wish to consider superior oblique surgery, but it's critical to understand that you will give the patient who's never had a problem with their superior oblique function some form of superior oblique weakening. It's best to make sure that you understand the primary cause and treat it if that can be done. These are more likely to resolve if they're inflammatory or from a cyst. And finally, a mild congenital Brown syndrome may not be noticed by parents until later in childhood as the child avoids the field of diplopia. So sometimes cases come in as acquired that really aren't acquired at all. Moving on to a new topic, congenital cranial dysinnervation disorders. You can see in this photo, this patient has bilateral ptosis and a chin-up posture. You can appreciate looking at the neck. So there's many congenital cranial dysinnervation disorders. This is a family tree and family members with CFEOM1, which is a very common form. It comes from a heterozygous missense mutation in the KIF21A, which alters something called kinesin. And in these cases, you almost always see an absence or an underdevelopment of the superior division of the oculomotor nerve due to misguidance and stalling of this branch. Because it's the superior division, you'll get a hypotropia because the inferior division is still working, and exotropia and ptosis. And you can see that in all these family members. You can really appreciate this very large chin up posture of the child with the shown to the right. These can be very challenging to treat. Here's a 17-year-old shown after a 17-year sequence of attempts to reduce this very extreme hypotropia, exotropia, and ptosis. This patient was treated by one of my partners and had been treated in multiple other institutions prior to initial attempts at Children's. He had multiple recessions and Z-myotomies of his inferior rectus muscle, bilateral superior oblique tenotomies, and levator resections. The superior oblique tenotomies to get rid of that last infraducting tone, and the levator resections, of course, for the ptosis. Multiple recessions and Botox injections of the lateral recti, and ultimately myectomy of the right lateral rectus and the medial rectus resection on the worst side. Finally, he showed on the picture on the right with minimal residual strabismus, but minimal movement of the eyes, both in primary position, and sufficient reduction of ptosis. But these can be very tough cases to treat. When we looked at a group of them and tried to summarize our experience, we found that from a surgical standpoint, you need to do profound bilateral inferior rectus weakening procedures, recessions of over 12 millimeters, sometimes even periosteal fixation of the inferior rectus muscles, myectomies or Z-myotomies of the muscles, and sometimes adding superior rectus resections. Most also require bilateral superior oblique tenotomies to extinguish hypotropia and to reduce exotropia, often seen after inferior rectus recession. What about the horizontal alignment? There's many dynamic forces at work. Many develop or have exacerbated exotropia after inferior rectus weakening. That's interesting. Well, the primary disinnervation results in convergence with attempted upgaze. So the exotropia you will see after surgery is masked prior to surgery as they converge with attempted upgaze, and it's definitely unleashed after inferior rectus recession. In addition, you lose the adducting capacity of the inferior rectus after these large recessions. With loss of inferior rectus tone, the superior oblique is the only infraductor, which can worsen exotropia, certainly in downgaze. However, unfortunately, weakening the superior oblique, which you often need to do to reduce that last little bit of infraduction, may also potentiate inferior oblique function, worsening the XT. So this is why they need so many procedures to get this under control. Here's your CFEOM3, or your tub mutation class. They have abnormal beta tubulin, altered axonal development and guidance, with also absence or underdevelopment of the superior division of the oculomotor nerve, so there's some overlap. But they have a more global impact. They often autistic, have facial palsy, cyclic vomiting, other neuropathies, whereas the CFEOM1s usually don't have these other neurologic characteristics. And here you can see in the imaging shown, the MRI imaging, the superior rectus and levator regions have very much smaller muscle bodies than the medial and lateral rectus and the inferior rectus muscles. Here's a CFEOM3 boy, an 8-year-old boy with strabismus his entire life. At age 1, he underwent surgery, bilateral lateral rectus recessions for very large exotropia, 10 millimeter superior oblique recessions, and his alignment essentially didn't change according to the parents, and he was diagnosed on the outside with Mobius syndrome. Not surprising with this very limited movement of the eyes in horizontal plane, and with also associated facial palsy. And here you can see what he looked like at that initial presentation at Children's. With the next procedure, the lateral rectus muscles were transposed to the orbital rims and the medial recti re-resected again, giving him nice centralized eyes, but really relatively immobile, but better off for the child and better off for eye contact. For the TUB3 CFEOM3s, you need to consider in the presence of other apparent neurologic dysfunction. It's a big distinguishing characteristic from CFEOM1. The Type 3 patients require profound weakening of the lateral rectus muscles combined with some form of medial rectus strengthening or resection. They have less severe hypotropia, and fewer patients have significant vertical misalignment or vertical surgery, and more tend to have corneal exposure keratopathy. So you need to take a close look at those corneas. New topic: myopic strabismus fixus, otherwise known as heavy eye syndrome. Form of acquired restrictive strabismus seen in a small number of patients with very high axial myopia. The axial length is usually greater than 30 millimeters, and the myopia usually in excess of 12 diopters, but it can be less in some cases. There's a progressive mechanical esotropia that occurs over the lifetime of these patients and often an associated hypotropia. And here's a patient with classic myopic strabismus fixus of the left eye. You can see this very large angle esotropia, complete inability to abduct the left eye. The right eye is normal in this case. Krizock was the first to look at this in 1997 with high-resolution imaging of 37 affected patients. He noted that the lateral rectus path was displaced inferiorly, on average about 3.5 millimeters in the anterior and mid-orbit. And you can see in this image to the left that the lateral rectus shown to the right is inferiorly placed. The muscle insertions were in the normal location, but the belly of the muscle shifts downwards, so the eye can no longer abduct very effectively. There was no suggestion in the imaging that contact of the globe with the orbital bones was responsible for restricted movement. Initially, it was thought that these very high myopes had very large bulbous globes hitting the lateral wall of the orbit, and that limited the movement, but that has subsequently been debunked. You can see here in red on the image to your left, 120 degrees shown, which is the typical amount of distance for heavy eye syndrome between the superior rectus and the lateral rectus. So you have nasal displacement of the superior rectus and inferior displacement of the lateral rectus associated with a kind of a supratemporal prolapse of the globe in this potential space. And once again, the mean angle between the lateral rectus and the superior rectus on imaging is about 120 degrees. If you work in an area where orbital imaging is readily available, this is a nice thing to check. In the absence of that, you can often appreciate that inferior slip of the lateral rectus. In the operating room, you'll find that there's a peaking of the insertion of the inferior oblique above the superior border of the lateral rectus muscle. The most common surgical treatment for this procedure is the Yokoyama procedure. This is a muscle union of the superior rectus and the lateral rectus, and it's a vessel-sparing procedure. This muscle union is created 15 millimeters from the insertion with a polyester suture. I find that it's almost always necessary to do a medial rectus recession at the same time because often over the course of time, the medial rectus has become quite tight because of poor lateral rectus tone. This relocates the globe back into the muscle cone, and you can see that at the time under anesthesia when you're doing this muscle union. It normalizes the direction of the superior rectus and the lateral rectus. Some have used silicone bands for this myopexy, or they've augmented the myopexy with multiple sutures, and these are all options. I have found that it works quite well using a single suture. So my preference is a muscle union surgery. It's vessel sparing, and this is very nice in a high myope. You also don't have to do the intrascleral pass. And I use a single suture, and I almost always use an adjustable medial rectus recession. I also find that the appearance under general anesthesia and the forced ductions pretty much predict what you'll see once the patient's awake. And that medial rectus recession will always be necessary with a primary esotropia of more than 40 prism diopters, but even sometimes in cases with lesser esotropia, and always with cases with greater esotropia. So here's a case. Patient had a 50 prism diopter esotropia and a 15 prism diopter hypotropia of the right eye, had a superior rectus, lateral rectus loop myopexy, plus a medial rectus recession to resolve the restricted strabismus. The hypotropia, of course, is because your superior rectus is now nasally displaced, it's not as good an elevator, and your lateral rectus is inferiorly displaced, which increases infraducting tone or tonus of the eye. Let's talk about strabismus after placement of a scleral buckle to repair a retinal detachment. The strabismus can be sensory in nature due to a loss of fusion because of poor acuity, and even due to anisoconia or difference in image size. However, sometimes the strabismus is simply mechanical because of muscle displacement at the time of trauma, at the time of the retinal detachment, or muscle displacement from the buccal itself, with cicatricial changes around the buccal. Sometimes there's entanglement of the superior oblique. The risk of strabismus is far greater with an encircling buccal than with radial hardware used to fix a detachment because the encircling buccal or band goes under all the rectus muscles. If torsional diplopia is present, consider seriously whether there's indication of some excess traction or twisting of the superior oblique or the inferior rectus. These tend to be the major causes of torsion in this setting. Most of the time, I find it's not necessary to remove the buccal to fix the strabismus. One can readily work around it. However, sometimes when you do this, you'll find that the buccal loosens and you need to remove either part of it or all of it. Check the sclera if you're removing the buccal, because sometimes you'll find a region of scleral malacia and you need to protect the eye. In any case, you ought to consult with the retina surgeon ahead of time to understand the level of concern regarding the risk of retinal redetachment in the particular case you're treating. Let's talk about operating over a buccal. First of all, you can remove part or all of the buccal, or recess or resect right over the buccal without removal. In this image, you can see examples of where a segment of the buccal has been removed and recession sutures placed just anterior to the buccal near the anatomical insertion, with the muscle recessed through that region that's been removed, or recessed from a region behind the buccal. Resection can be accomplished in a similar fashion. I find, however, usually I can leave the buccal in place, so I do not need to worry about the possibility of unroofing some scleral malacia, and I find that I can place my sutures either anterior to the buccal or posterior to the buccal, and interestingly enough, the muscle will assume its proper location and will heal with the sutures running simply over the buccal. There's a short video article we did in JOPOS where this area, which was under a buccal that had a bridge of existing tenons, had complete scleral malacia. And in this video article, not shown here, you can see how we used a pericardial patch graft to protect this area from the possibility of globe rupture with inadvertent trauma to the area later. Let's move on to craniosynostosis. First of all, it's a very common disorder. It's present in 1 in 2,500 live birth, and it's premature fusion of the cranial sutures during pregnancy and through the first years of life. There's loss of skull growth perpendicular to the fusion and compensatory growth of the skull elsewhere. So this is a classic case of unicoronal synostosis, where you have a fused coronal suture on the right and compensatory growth on the left side of the skull. And you can see in the imaging below a flattened forehead on the right and an elevated, more open eye, and a more closed eye on the left, where you have frontal bossing and the superior orbital rim pushes down on the eye. There's also syndromic craniosynostosis, which involves multiple sutures. Here's a classic Apert patient with a towering skull, multiple sutures involved. You can see from this reconstruction from orbital imaging how tight the brain was against the skull, because you can see the rugations of the brain against the bone. We call this prominent convolutional markings. That is a classic sign of elevated intracranial pressure, even in utero, putting those impressions on the inner table of the skull. The picture on the right shows you the child post-syndactyly surgery. Often these children are born with a kind of a stocking glove deformity with a separated thumb and the rest of the fingers fused together. Sometimes all 5 fingers are fused together, and they get multiple procedures in childhood to separate those fusions. The feet are fused as well. If you see a child with a funny-looking towering skull, possibly papilledema, funny strabismus, and fingers and feet that are fused together, it's Apert syndrome until proven otherwise. Pfeiffer syndrome, another syndromic type, has a lot of mid-face retrusion. You can see the bridge of the nose and the upper area of the lower orbit is really pushed backwards. These patients very commonly have obstructive sleep apnea, short, stubby thumbs. Here's Crouzon syndrome, more of a bicoronal synostosis, less atypical appearance, and your Sather-Schotzens, who are the most typical appearance, mostly have a lot of ptosis and lacrimal disorders. Fewer have strabismus or elevated intracranial pressure. The strabismus associated with craniosynostosis, however, is V-pattern strabismus, regardless of the type. The classic strabismus is due to retrusion of the superior orbital rim, which almost always accompanies coronal synostosis, whether it's unilateral or bilateral. You have retrusion of the superior orbital rim, which increases the laxity of the superior oblique, giving a kind of superior oblique palsy. When these children are treated, if they are treated with a large cranial vault procedure, there's inadvertent stripping of the trochlea at the notch during cranial vault expansion. The image on the bottom on the left shows you an exposed brain. To the right, you see the child has been scalped and the skin and dura pulled over to the right. The arrow is pointing to an eye. The periorbita are stripped away and the notch is cut. And there's passive reinsertion of the superior oblique after such a procedure. Not all children are treated by this type of cranial vault expansion at this time, but many of them who have been, and some continue to show signs of superior oblique-like palsy. There's also other reasons for V-pattern strabismus in this population. They have an abnormal tilt of the orbit. And in this case, with this excycler rotation or abnormal tilt of the orbit, this is a child who had unicoronal synostosis shown on the left side of your image, the child's right eye. The medial rectus elevates the eye with adduction. The lateral depresses the eye with abduction. The inferior rectus adducts the eye with depression, and the superior rectus abducts the eye with elevation, giving you this sort of V pattern. In certain cases, the extraocular muscles, particularly the superior oblique, may even seem absent or small on imaging, or replaced by connective tissue. With modern imaging, you'll almost always see the muscles because they're much higher resolution, but they're not always made of typical muscle tissue. So how to address V-pattern strabismus in this population? First of all, you need to look at the severity of the syndrome. Are there bony and extraocular muscle abnormalities? You need to look at the severity of the V pattern. Where is the pattern most severe? Is fusion present? You need to think about the timing of craniofacial surgery. And you need to think about the impact of craniofacial surgery, potentially on the alignment of the child. Here we have a case of a child with unilateral coronal synostosis with fusion. You can see from the imaging on the right that he had a harlequin deformity. And by age 2.5, he had 3+ overaction of the inferior oblique and 3- underaction of the superior oblique on the right eye, causing this head tilt for fusion. The head tilt was large. It was 30 degrees to the left shoulder. He had an inferior oblique myectomy on that side, followed 6 months later by a 6mm tuck of the superior oblique. He had an excellent outcome, as you can see, with resolution of his 30 degrees of ocular torticollis and restoration of 50 arc seconds of stereo. Many of these patients can be successfully treated, and if they are fusing, my recommendation is to treat them early, not late. Even if they have later cranial vault surgery, reoperation, I have found that it rarely impacts the strabismus they've had early on. Here's a child with asymmetric bone deformity, unicoronal synostosis with greater excycler rotation of the extraocular muscles. You can see on this imaging on the right side of the slide, there's more twist to the right eye, less to the left, a moderate tilt to the orbit, and excycler rotation of the muscles, a head tilt of about 25 degrees. But in this child's case, a nearly concomitant right hypertropia. So I did a superior oblique tuck and an ipsilateral superior rectus recession because this hypertrophy was quite large and concomitant. We found normalization of ductions and versions, but only a reduction, not complete elimination of her torticollis, only from 25 to 15 degrees. So it was my impression that she had a combination of ocular as well as non-ocular torticollis. In some of these patients, they've had such a long-standing head tilt that you can't get rid of all of their torticollis. And I send many of them for physical therapy after surgery to make sure the neck muscles are free. More severe V pattern from aperts, Pfeiffers, and Crouzons. Once again, you need to take a look at the severity of the orbital abnormality or asymmetry, severity of extraocular muscle excycler rotation, severity of muscle dysgenesis, whether there's fusion, and you need to think about superior oblique surgery for sure in many of these cases. What about superior oblique surgery? Well, tucks work well if the anatomy is reasonably intact, reducing all aspects of the V pattern. May also reduce excycler torsion. and may reduce torticollis if fusion is present. If there is no fusion, there is no strabismus surgery you're going to perform that's going to functionally reduce much of the torticollis. Important caveats. If the superior oblique is very lax, you need to utilize a supramaximal tuck. Think of the kind of tuck you might do with a profound congenital superior oblique palsy. Occasionally, there's poor embryological development of the muscle. If there's been disinsertion and passive reinsertion of the notch during a fronto-orbital advancement, the superior oblique may be desagittalized or pushed further back, and there may be minimal angle at the notch. So the superior oblique goes back almost directly to the posterior orbit, almost like a lateralized superior rectus, and you won't get much impact on reducing torsion by tightening it because there isn't that wonderful torsional aspect of the triangulated shape of the superior oblique. Here's a case of reducing torticollis when fusion is present in a child with multi-suture synostosis. This child had no palpable superior oblique notch, so extreme superior oblique laxity. An inferior oblique myectomy was performed along with a very large superior oblique tuck, about 20 millimeters. You can see that prior to surgery, he had a very large head tilt to the right of about 32 degrees, but he did have 100 arc seconds of stereo, and we were able, in this case, to reduce the torticollis from 32 to 15 degrees, a definite improvement. Here you see a case of severe torticollis. This child has Pfeiffer syndrome with a severe chin-up posture of about 48 degrees. You might also note the hearing aid on her headband. Many children with Pfeiffer syndrome have abnormal ear canals and hearing deficit. She had extreme limitation of elevation, especially in abduction. The images of her motility, the top two, show her attempt at elevation, but she can't elevate either eye. She can infraduct quite nicely. The imaging was unremarkable with respect to the extraocular muscles. You can see that they're fairly symmetrically placed, and this is a good example of how the imaging can show what appears to be normal muscles, but they may not be normal when you see them in the operating room. And she had near agenesis of the extraocular muscles, totally free force ductions. The inferior recti were not tight, no restriction of elevation, no palpable superior oblique or inferior oblique. The inferior recti were completely lax diaphanous. They were maximally recessed. The superior recti were equally diaphanous, and at the time of surgery, I did not bother to resect them because I didn't think it would help very much. In retrospect, that might have been helpful. Her head posture from these supramaximal inferior rectus recessions was improved, but she still had limited elevation, and perhaps a second procedure of superior rectus tightening would be indicated, but the parents were quite content with her current alignment, and they did not pursue this. Thank you very much. I'm pleased to have had the opportunity to teach you something about these atypical and unusual forms of strabismus. Hope it's been helpful. Thank you. Bye-bye.
Well, Linda, that was wonderful. I certainly learned a lot. Part of my job as moderator is to comment on if anything wasn't clear, to perhaps ask for clarification. Everything was perfectly clear, as I expected. But I did have just a couple of questions I'd be curious for you to comment on. Back in the day when I was training, when prior to there being expanders of the superior oblique and split tendon lengthening and so on, the treatment for Brown syndrome was a tenotomy of the superior oblique. And I think it was in the 60s they observed many of these patients ended up with a subsequent superior oblique palsy. So I believe it was Jack Crawford popularized the idea, and Marshall Parks also was on board with this, of simultaneously weakening the inferior oblique at the time of superior oblique tenotomy. Is that approach not ever needed now with the procedures that are being done now for Brown syndrome? Do you have experience with that?
I do. And I would say, honestly, that is a very simple and straightforward technique. A complete tenotomy and an inferior oblique myectomy or some form of significant inferior oblique weakening is a reasonable option. And so for people who aren't comfortable placing a suture spacer or fear they won't get the length of the spacer correct, I think that that's a very reasonable option. The idea behind the suture spacer was to avoid the need to perform inferior oblique surgery at the same time, and to have a more graded approach. I think if you perform a complete tenotomy, the risk of superior oblique palsy without an inferior oblique weakening procedure is probably 80 to 90% over time. You may not see it right away, but you will over time when the inferior oblique overacts. And we found about a 30% rate with a graded tenotomy, but only a 10% rate if you treated with a graded tenotomy with that hypotropia of less than about 16 prism diopters in lateral gaze with a deduction. So that might be, a guide for when to use a tenotomy and when not.
That mirrors my experience. Initially, just doing a tenotomy, superior oblique palsy, almost inevitable. And for a long time, before I switched to some of the newer procedures, combining it with an inferior oblique weakening took care of that in most cases. The other thing I'd be curious for you to comment on, I agree, I was glad that you said that in cases with scleral buckles, you can, even on a hangback, or I prefer the term suspension, have the muscle over the buckle and it will adhere. But the approach that I've taken is often when operating on a patient with a prior scleral buckle, the fibrous sheath that surrounds the scleral buckle stays intact, and the muscle will adhere to that fibrous sheath. But if in the course of dissection, for some reason, I wind up bearing the silicone, and I'm looking just at bare silicone, I've always been concerned about the muscle adhering to that. And in those cases, I'll either use a non-absorbable suture or modify my technique in some way that I'm not having the muscle right on top of the bare silicone. Do you find it will adhere if the silicone is bare, or is that not an appropriate dichotomy?
No, I think that's a great thought. And there's certainly nothing wrong with using a permanent suture like a Merceline. In such cases, I haven't actually found it to be so much of a problem. I think what happens is that the muscle adheres to the globe just posterior to the band and almost acts like a faden, and that's where the adhesion forms.
Okay. Well, I think that was just superb. Linda, I want to thank you so much for taking the time to do this. I learned a lot. I'm sure our audience learned a lot. And I'll say to the audience, if you enjoyed this lecture, which I'm sure you did, please tune in to all of the lectures in this series. They're all available to you. And with that, I'll wish everybody a good day, good morning, good evening, depending on what part of the world they're viewing from. Thank you.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.